Good afternoon, everybody. Can you hear me? So please, let's take our seats. We're going to start. My name is Serge Capta. I'm a policy specialist on data for development in UNDP. I have the pleasure of moderating the launch of this report. I hear that we're online, so I'm going to hold it up so the cameras can see it. So the Global AgeWatch Insights report, which is being launched today as part of the Universal Healthcare Coverage Day. So I have an August panel with me where we're going to hear more about the report and some country experiences. I have to say that the issue of aging, I think is coming of age, if I can say so, in the international development agenda. And I'm quite pleased to be working with our partners such as AARP, HelpAge, as well as the countries like El Salvador that are championing this issue on the global development agenda. We need more of these kind of partnerships and friends to ensure that this issue, which is quite critical for the world and the trends, the directions where the world is going, be addressed properly in our development and humanitarian agendas. Now, I'm not going to speak too long about it. I think we're going to have an interactive debate. I'm going to go straight into introducing our panel. Before they speak, I'm not going to introduce all of them now, but just before they speak, I'm going to introduce them. So before, we're going to get started with some welcome remarks by Amy Carter, who is Vice President at AARP. I had the pleasure of meeting Amy just recently as she joined her new position, and she has a quite challenging task, which is to ensure that there is that thought leadership that we seek on aging is assured, coming particularly from AARP, but working with many of the partners. She worked previously with the Council on Foreign Relations and with Booz Allen Hamilton, and did a lot of work on analyzing the business environment and making policy recommendations in many countries. So that's an expertise that is quite useful for our agenda on aging. Amy, you have the floor. Thanks.
Thank you, Serge. And good afternoon, everyone. Thank you all for joining us. First, I want to start by recognizing and thanking Ambassador Ruben Hasbun, permanent representative of the permanent mission of El Salvador to the United Nations. I also want to thank our partner, HelpAge International, and our co-sponsors, the World Health Organization and the UN Department of Economic and Social Affairs, and last but not least, Serge, our moderator for today. Serge is from the UN Development Program. Far too often, as we know, older people are omitted from important developments on health and well-being. It's time for decision makers from all sectors, from government, multilateral agencies, national statistical offices, and civil society organizations to really take coordinated action to ensure inclusivity and to guarantee older persons' rights to health and to quality, affordable health care. And so AARP is pleased to have partnered with HelpAge International to produce and release this report today on the occasion of the UN's Universal Health Coverage Day. So we're looking forward to hearing more about the Global AgeWatch Insights report that really focuses on the right to health and the right to be counted. So for those of you who do not know, AARP is the largest nonprofit, nonpartisan organization in the United States dedicated to empowering people 50 and older to choose how they live as they age. With a nationwide presence and nearly 38 million members, AARP strengthens communities and advocates for what matters most to families: health security, financial stability, and personal fulfillment. We also produce the nation's largest circulation publications called AARP The Magazine and AARP Bulletin. And on the global front, AARP works with partners around the room here and around the world to elevate aging and longevity as the global trends that they are. We also work to identify and share best practices and innovations from around the world, and also to bring more audiences into the conversations on aging and to spur actions. So again, thank you for being here, and I'm looking forward to the presentations this afternoon and to having a really robust conversation on this really important issue of universal health coverage.
Thank you, Amy. Thanks for those kind words and welcoming remarks. Without further ado, I'm going to turn to His Excellency Ambassador Ruben Escalante Asbun, who is the permanent representative of the permanent mission of El Salvador to the United Nations. His Excellency Mr. Escalante has quite a distinguished career in diplomacy and international development. He served with the El Salvador presidency to the Committee of Latin American Caribbean States in Brussels, and before that he held various leadership responsibilities in the permanent missions to the United Nations in Geneva and in New York. I understand that Mr. Escalante has quite some keen interest on issues of human rights, disarmament, humanitarian, and environment. And I was quite pleased to be interacting with him recently on issues of multidimensional poverty as well, which is quite critical as well when it comes to the aging agenda. Excellency, you have the floor.
Okay, I was just told that I only have 5 minutes. Can I? Thank you. Yeah, he's the moderator. So, okay. So, I'm going to be timing myself. Thank you very much for the introduction. I'm really happy to be here. It always feels like a homecoming to me every time that I come to an aging-related event. I see so many faces with whom we fought the good fight back in the day. And we're still doing it, but I just don't get a chance to actually get into the negotiating room and actually fight for it. But I do make a lot of phone calls back home and also to all the other PRs. And even though I'm the only PR who's going to be speaking to you today, yes, I just want to remind you that there's actually a big number of member states who are supporting all the aging-related issues here in New York. I am just the representative of one of them and the representative of one specific group of friends that has been gaining a lot of members. We are really happy to welcome Canada, for example, as our latest edition. Yeah. So I'm going to be talking to you in the little time that I have about 2 dimensions on the issue of universal health coverage. One is the national dimension, and what is the international, basically what we do here. And I do believe that when it comes to cooperation between governments and civil society at the UN, we need to be specific and we need to map out who's going to be doing what, when, at one point in time, and here in New York, in Vienna, when things are going to be happening, just to make sure that we are actually focalized enough and that our efforts are going to pay off. Without either forgetting that the issue of aging is cross-cutting, and as much as there is a group of friends on aging, there's also a group of friends on universal health care. And there's a group of friends of many other things through which the aging agenda needs to be implemented. So first of all, the issue of national implementation. I think throughout the years, the cause for universal health coverage has been gaining momentum at the international level, both here in the UN and also at the inter-American level, which is the part of the world that I come from. But we need to remember that at the end of the day, when it comes to implementation, we're talking about politics, internal politics. And this is where reality is actually going to be taking place or not. And we need a lot of voices also coming from the UN and coming from NGOs, both national NGOs and international NGOs like HelpAge, and I also count AARP as an international NGO for all the work that they are doing here at the UN, in actually convincing everybody that universal health coverage actually makes sense. And I'm telling you because obviously it implies money, obviously it implies making sure that we rechannel resources for the national budget. National budgets are approved and discussed at Congress, where more than one political party is sitting. And the government, as convinced as he may be about the issue, needs to convince also the opposition parties to make sure that when negotiating the budget, things are going to be put in that regard. And then it comes the other issue of where do you get the money from? And one of the big things, and we have been talking about multidimensionality of poverty, you know that we are classified as a middle-income country. And many 120 plus, I think there are 109 plus, are classified as middle-income countries throughout the world. And the 2 things that we have as spending issues when you're a middle-income country is you're taxation-based. we still have a big chunk of the population who are part of the informal economy, and we do have a huge tax evasion. So to make sure that we're going to be able to afford universal health coverage, we need to make sure that we, combat tax evasion, and also that we bring as many people as taxpayers. But people don't want to pay taxes unless they see results. So at the same time as we are convincing people to pay more, they need to see an improvement of the public services. Otherwise, the perception of corruption is going to increase. And this is just like a glimpse of the issues that we are dealing with. And I'm sure I'm not going to be the only one. When it comes to actually putting universal health coverage at the table, especially for people over 60. It is a struggle. It is a struggle that we are convinced that we should win. But when you come to the actual reality in the ground, it is far more complicated, and that's why we need the support and the voices from civil society and also the UN. And it's so, oh my God, I'm 9 seconds away. Can I have a couple of minutes? Yeah, okay. And then just to complement that, and as I was telling you, we need the voices of the UN. It so happens that we and many other countries in the world are quite sensitive to what the UN says. You will come to El Salvador, for example, and whenever we have a visit of any, be it a representative of the Secretary General or a member of any of the treaty bodies in Geneva, people do listen. And all the political parties do listen. So we need to make sure that as many representations and representatives of the UN do talk about it whenever they refer to specific countries. And this is the other side of the conversation. What we do here and how we're going to be mapping our efforts. And if we look ahead, I think there are certain moments that that are going to be exciting for us. We obviously have the high-level meeting on NCDs that happened in September. And the legal battle and the political battle was fought here. We just need to make sure that all the institutions, including obviously the World Health Organization, is going to be paying attention to that. If you have a look at our chapter in the Insights, we are one of the 12 countries to be lucky enough to be featured. The issue of NCDs is highly prominent in terms of the morbidity and mortality that we have of people over 60. The other being domestic violence, specifically in the case of all the women. That is one thing. And the other one is the actual negotiation towards the high-level meeting on universal health coverage that we're going to be having next year. Tomorrow, we are going to be adopting the modalities for that particular high-level meeting. So that's another thing to look forward to. And another exciting thing is that for the first time in a long time, the open-ended working group on aging is actually going to have teeth. So in the resolution that we had in the third committee, for the first time, we were able to secure funding to make sure that the dates are moved to a more exciting part of the calendar. I think it's going to be taking place in April this year. And together with Argentina, who's the chair of that open-ended working group, we are thinking about ways of making it more, I'm going to use the word binding, which is taboo, but you know what I mean, right? Like that we actually have outcome documents that can be quoted, through which we can actually promote issues related to universal health coverage of that particular population. And in Geneva, again, World Health Organization, and for as long as we won't have an international convention on the rights of older persons at the UN, we need to make sure that the implications with all the other conventions are highly seen. And when it comes to the right to health, you're talking about the Committee on Economic, Social, and Cultural Rights. You need, and we all need to be speaking to those members of the committee to make sure that whenever they review a country's report, they do talk about it. And whenever it's not being reported, they do bring it up. And whenever a member of the committee wants to do something they call I think, what is it called? The common... What do they call that? No. It's called as you can see, I'm not following any talking points. So all the members of all the committees have the individual right of actually putting forward ideas for common. I want to say comentarios generales, which is the general comments. Let's call it general comments of the committees. So, which is a way in which the committee actually creates jurisprudence about how to implement that particular convention. And we need to convince those members to put forward general comments about the implementation of the right to health when it comes to older population. So as long as we have clarity of what we're going to be doing and when and where things are going to be taking place, I think we can be focalized and effective. And I actually have to go to another event. My friend Hara, who's behind me, she's going to be sitting in my place. And I promise that if anybody wants to get in touch with us, she's going to be collecting any cards or any information, and I will be sending you an email probably tomorrow. So thank you again for the invitation, and I have to go. Thank you.
Thank you, Excellency. I think that we have there quite an excellent blueprint and great suggestions on how to advocate for aging and universal health coverage in the Global Development Agenda. Thank you, Excellency. I understand you're going to be leaving us. Yes. Pleasure seeing you again. Now we're going to talk about the Global AgeWatch Insights report itself, and I have the pleasure to introduce Patricia Conboy, the head of Global Aging Advocacy and Campaigning at HelpAge International, and I've had the pleasure to work with Patricia quite closely in the recent months to advocate for statistics on aging. Patricia has been working with HelpAge International in her capacity of health as head for global aging since 2016. She leads a team whose collective aim is to advance the rights of older people in low and middle income countries through progressive policy change and implementation. Prior to joining HelpAge, she was with the Director of Older and Bolder, that's quite a mouthful for me, which was a campaigning alliance of NGOs in Ireland. Patricia will present the main findings of the report for us. I understand that you have some slides. Are they loaded? Yes, they are on the screen. So, Patricia, you have the floor.
So, good afternoon, everyone. It is a great pleasure to be here today on Universal Health Coverage Day in partnership with AARP to speak to you about Global AgeWatch Insights. Thank you, Serge, for your kind introduction, and it is a great pleasure also to share the panel with our partners from World Health Organization and from UNDESA. I'd like to begin by saying that growing old is not a new human experience. But the way we are aging now is new. The older people of today are on the front line, so to speak, in terms of how aging is happening and that experience. But how we as a society respond to that experience is a matter of great import for people of all ages. So whatever age we are in the room, and indeed our colleagues online as well. And in Global AgeWatch Insights, AARP and HelpAge have collaborated to look at experience of aging in low and middle income countries through the prism of health and data. In my quite short presentation, I hope to say a little bit about the rationale for the work, some of the challenges we've identified, and some of the actions that we deem necessary to address those challenges. And I hope that I'll also be able to pick up some of the remarks that Ambassador has made from El Salvador, which are very helpful in terms of the path forward. You may ask, why now in relation to the right to health for older people? And of course, we're at a particular moment in 2018 and going forward. We have marked the 70th anniversary of the Universal Declaration of Human Rights, which established the right to health for everyone. And it seems timely to think about how that right has been realised or not for the people who have grown old, if you will, in the generation or in the timeline of the Universal Declaration. We have a great opportunity in terms of Agenda 2030 and the focus of SDG 3 on health for people of all ages, and in turn on the global drive towards universal health coverage. And of course our question is, to what extent will older people benefit from this global drive towards universal health coverage? There are 3 transitions that we address in the report. The first is the demographic transition, which I know we're familiar with now and it's much higher on the agenda than would have been the case in times past. But 70% of the world's older people live in low and middle income countries. And there's a gender dimension to how our populations are aging as well, with women outliving men globally by an average of 4.7 years. We're experiencing an epidemiological transition with a global pattern of disease that is shifting from communicable to non-communicable diseases. And 75% of deaths from NCDs in low and middle income countries in 2011 have been of people aged 60 and over. In this context, it's clear that our health systems need to adapt, and I'm going to illustrate that in a moment. But also that if that kind of adaptation is to take place, that we need good data to inform our planning and our policy development and implementation. And indeed, as we would have expected in HelpAge and in AARP when we were developing the project, we did encounter tremendous obstacles in finding good data at national level to explore some of the issues we wished to explore in relation to ageing, health and universal health coverage. So we've made considerable use of the Global Burden of Disease study from 2016, which is the data from which is published or available through the Institute for Health Metrics and Evaluation. So I'm just going to ask you not to worry about the detail of this slide, but simply to see how much of the slide is covered in the colour orange, almost all of it. And it's basically showing across the 12 profile countries that we examined for Global AgeWatch Insights what the distribution is of years lived with disability due to non-communicable diseases. So you have much smaller sections in grey for injuries and much smaller sections in red for communicable diseases. And what we're, though again, if you look at the African countries, you can see that the communicable diseases, there's still stronger sort of presence of communicable diseases in those settings. So obviously what we're saying is that for older people, we know that life expectancy is increasing. Healthy life expectancy is not actually keeping pace in the same way with life expectancy. And we have older people whose lives are marred by unnecessary disability due to NCDs that are not caught in time, diagnosed in time, managed in time, and so on, and other forms of ill health. So these are some of the issues that we want to tackle and bring to the table in terms of work going forward. In the report, we've included some findings from a survey conducted by the World Health Organization as to reasons why people over 60 in different parts of the world had difficulty in accessing health services. And again, I'm just going to draw your attention to the right-hand column in low-income countries, where you can see that inability to afford the service was a barrier for 60% of the respondents in that survey. That for 29%, the lack of transport, and for 33%, the fact that they couldn't afford transport. These were issues in terms of being able to access services. And then if we come further on down the line, we can see there's a line where people talk about having been treated badly previously. 8.3% of people were reluctant to access services due to previous bad experience. And if we go across that line to high-income countries, we can see it's 23.8%. So it hasn't been examined in this study in terms of ageism per se, but we do know, and it is something we need to find out more about, but we do know that anecdotally, older people in high, middle and low income countries report difficulties in having some of their conditions taken seriously and recognised and understood. So the the little story that really captures it for me is the story of a woman from South Africa who says, I went to my hospital to talk to the doctor to ask for treatment, and he told me there was no pill for old age. And that to me sort of says something about where we have to go, and this could apply in any setting, in any hospital, in any setting, but where we have to go in terms of better understanding of what is possible in terms of health and functional ability in later life. So, just picking out some trends in relation to ageing, gender and health in the Global AgeWatch Insights report. That whilst women live longer, they actually live a greater proportion of their lives in poorer health than men. So if we were to summarise, we would say that the issue for men is higher mortality and for women higher morbidity. In all of the profile countries, first of all, we'd say in relation to dementia, it causes 5% of years lived with disability globally for those aged 70 and over in 2016. The prevalence was higher for women in all profile countries. In relation to depression, again, the levels were higher for women in all countries except Myanmar, the profile countries. In relation to violence experienced by women and men, it was higher for women than men in all of the profile countries. And interestingly, in terms of, and not surprising, I think, because it's a global trend, in terms of self-harm mortality, which includes suicide, that was higher in profile countries among older men than women. And I think in 8 or 9 of those countries, it was also higher among older men than younger men. So when you have a chance to look at the report, the levels of self-harm mortality are not extremely high, but there's quite a bit of variation in trends between one country and another. And it was beyond our capacity to explore that, but it would be interesting to do that. In terms of universal health coverage, there are gaps in the data that we would need to adequately measure how older people are accessing universal health coverage or benefiting from it. The 4 headings that you see here are the 4 components of the right to health as identified by the Committee on Social, Cultural and Economic Rights, which we referred to earlier. So the availability of health services, the possibility of accessing them, acceptability in the sense that a service should be able to meet the needs of different groups of people. So if I'm an older person with disability, or if I'm an older woman with particular issues in relation to the menopause or whatever it may be, that the service is actually able to address those needs. And the 4th one being quality, the quality of the service. So what we have looked at in relation to availability is basically a recognition that with universal health coverage, an index is used to measure the basket of services that is available through universal health coverage. And ratings are applied or scores are applied to countries in relation to that index. From the perspective of older people, the 2 services that are of particular relevance are hypertension and diabetes. But the situation is that the data from which the measures are drawn very often excludes people over the age of 64 or over the age of 69. So even though this measure is important for the SDGs and important for every older person in terms of their lives, we simply don't have the data we would need to adequately measure how older people are accessing those services. Now, I also want to acknowledge that I know that the World Health Organization is cognizant of this and working on extending indicators in the context of an impact programme related to their new programme of work. In terms of accessibility, we had great difficulty in finding anything more than data from small or scattered national surveys in relation to transport or in relation to people's distance from services, and also difficulty in relation to the costs of universal health coverage or of accessing services. So we know one of the aims of universal health coverage is that services should be affordable. But the data that is gathered, for example, for the SDGs is gathered at the household level. And where per capita data was available through the sources we looked at, it wasn't disaggregated by age. So there may be sort of particular countries that are able to produce this, but in the situations we were looking at, we found it very difficult to find that kind of data. In terms of acceptability, we could not find data, and in terms of quality, the issue we looked at again was that of evidence. What's the evidence there to support proper planning and quality of the services? So we noted, for example, that I think it was 34 of the 40 countries in Africa where the STEPS surveillance study had been implemented to track progress in relation to NCDs. It actually did not count or include the experience of people over the age of 64. So I'm just going to take a small drink. In relation then to going forward, there is action that we can take together in terms of health systems, data systems, partnership working, and I'm going to address each of those in turn. So in relation to health systems transition, I'm very conscious that we are speaking about the transition from communicable diseases to non-communicable diseases, and that it's really important to gather a picture so that we are spurred to action in terms of the level of disease that is prevalent amongst older populations. But we're very clear in saying that health services, as they evolve, and this applies to universal health coverage, needs to be person-centred and to respond to individuals and not to diseases. And one of the issues in many high-income countries is that you would have very entrenched, siloed systems that are responding in terms of diseases rather than in terms of persons. And I think there is scope in low and middle income countries where things are evolving to really do things differently. To integrate the services with consideration of care where people need ongoing social care and support to maintain independence, and to be holistic in approach. So if we go back to the slide I showed earlier in terms of depression, in terms of self-harm mortality, in terms of dementia, in all of those areas it's much harder to get both the data but also the same level of attention as we give to physical conditions. So this is why we place such an emphasis on person-centred and holistic care. I gave you the story of, which I would have heard more than once, of the individual who goes and doesn't get the treatment they need for the condition they're presenting at a hospital or a clinic. And what we're saying is that the health workforce needs to be trained. So we're not asking for multiples of geriatricians to be employed in particular countries, but that all staff would actually have a degree of geriatric or gerontological competence. So they're actually aware of and trained to respond to the needs of older people as to the needs of people of all ages. That health information systems are set up so that outcomes are analysed and captured to inform planning. And where, as we know, there are health systems in place in health centres and where administrative data is being gathered and so on, that we make better use of that data but keep a level of disaggregation so we know what's happening to people of different ages within that system. That essential medicines particularly for people for conditions in later life are available. Ideally that financing would be free at point of access, and I know that's a very big ask, but it is possible in terms of our leadership and our governance to ensure that older people and ageing are adequately included in our laws, in our strategies and our policies. So these are some of the elements we see as being necessary in terms of health systems transition. Moving on, in terms of improving data on ageing and health, thinking in terms of data collection and analysis, we ask that upper age caps be removed from international surveys. That as well as relying on household surveys, we actually collect data directly from older people, whether through once-off cross-sectional surveys or longitudinal surveys. that we don't ask the impossible, but we invest in capacity and resources of national statistical offices, especially in low and middle income countries where that kind of resourcing is essential, and provide support as well around the development of civil registration and vital statistics systems. And that indicators that are relevant to ageing and older people are extended in terms of the measurement of universal health coverage. In terms of reporting and use, again, many of the national surveys that colleagues looked at, they found difficulty in actually using in our report because aspects of the information about samples were missing, things, or the data wasn't timely, things of that kind, or else there was an impossibility in terms of comparing the data between one survey and another. So we're asking for clear guidelines in terms of consistent analysis and reporting, data to be published in a timely way, disaggregated by age, sex and disability. And that where there are unnecessary restrictions on access to microdata, so where institutions have maybe privileged access to a survey, that really needs to be looked at so that, and we know some data is open source, but where more data can be open source, obviously taking account of confidentiality of individuals and so on. And finally, that in terms of partnership working, that we engage with the Titchfield Group on Ageing-related statistics, which is addressing these issues proactively at the moment, and Serge has been involved with this group as I have myself. Coming on then to the final area in terms of partnership working is to remember always that the lived experience of ageing rests with older people. We can't tackle these issues without, or find out if services are acceptable, for example, without speaking with older people. We can't know if we're adequately measuring person-centred care unless we engage with older people in terms of how they're experiencing the care they receive. So I think our message around working in partnership with older people is a very important one. And finally, thank you very much for listening. You can find out more at the www.globalagewatch.org website. Thank you very much indeed.
Thank you, Patricia. I think that was an excellent presentation of the report and its findings. Again, the website is www.globalagewatch.org. You can download a copy of the report. I have to say that I was quite pleased to see that the report is taking very much a rights-based approach and an equity-based approach as well, which is quite in line with the Leave No One Behind mandate of the 2030 agenda and the necessity of reaching the furthest behind first, which we sometimes forget. And I think that rights means accountability. Really, I think it's quite important here, and that goes back to what His Excellency the Permanent Representative was saying earlier, that we need to map out who has to do what and track who is doing what to ensure that this agenda is these rights are met, are satisfied. So I would encourage you to look at the report. The report actually outlines the recommendations in terms of what each stakeholder groups can do, civil society, government, as well as international organizations and national statistical offices. I'm going to turn now to the World Health Organization, Mr. Werner Obermeier, who is the Deputy Executive Director of the New York office of the World Health Organization. Just for introduction, I would say that the most important thing I can say about Mr. Obermeier is that he is leading the preparation for the High-Level Meeting on Universal Health Coverage, right? So that's quite an important role and a perspective that is bringing to our discussions today. Obermeier, you have the floor.
Thank you, Serge. Indeed, this will be a milestone for the UN, like today is. Happy Universal Health Coverage Day to you all. Let me start by emphasizing that UHC, as we call it, means that all individuals and communities receive health services they need without suffering financial hardship. This is the one component of it. But it also includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. So the whole spectrum should be covered. By 2050, 1 in 5 people in the world will be 60 years of age. or older. And one of the hallmarks of older age is, of course, a great diversity of health and functioning. Since this is often a consequence of the impacts of advantages or disadvantages in life, policy responses need to be crafted in ways that overcome rather than reinforce these inequities. Population aging will have an impact on the ambition of universal health coverage because without considering not only health but also the social care needs of the ever-increasing numbers of older people, we will not be able to achieve UHC. I think it has already been mentioned that Sustainable Development Goal 3 cannot be met without transforming health and social systems from a focus away only from disease towards provision of integrated and person-centered care. And that we know it has the greatest impact on functional ability in older age. So implementing these changes demands shifting away from a more disease-oriented financing, resources and management towards a people-centered agenda that values health again. Older adults require different approaches to healthcare and often are less able to pay, as you have heard from the previous presentation. So what we have done in WHO is identify how we should realign health systems to meet these targets. And the strategy that we have developed has certain objectives and goals, which you could find on the WHO webpage. I'm not going to go into all of that to save time. The strategy is called the Global Strategy and Action Plan on Aging and Health, and it provides kind of a roadmap for how to reach this transition that we are talking about, transitioning health systems. This process pays specific attention to a number of areas. Firstly, to organize services to respond to older people's diverse levels of capacity as well as their needs and preferences. Secondly, to extend coverage of services to all older people, not only those that are in the formal but also in the informal workforce, and particularly those who fill caregiving roles, because they have often the less access to basic health services. Thirdly, to ensure that coverage extends to services that provide interventions that are important for capacity and functional ability. And with this we mean assessment and care plans, restorative surgery, assistive devices, functional nutritional supplements, physical exercises, and long-term care. And the fourth element is to develop sustainable financing mechanisms that can protect older people and their families from undue financial burdens. The most common shortcomings of health benefit packages where they are available are actually that they do not include interventions that are key for maintaining this capacity and functional abilities of older people. That's often lacking. So when you look at surgery related to cataract, knee, hip replacement, assistive devices, it often in developing countries, these services are not covered. So the design of more integrated and transformative health systems should take into account these shortcomings and also encourage countries to foster better integration, like I have said, not only between health but social care, and to improve and maintain older adults' physical and cognitive capacities. Most of the current social insurance schemes also cover employees mainly in the formal sector, not informal sector. And obviously coverage needs to be extended to include retirees or older people that have spent their whole life in the informal sector, and Ruben has mentioned what large percentages these often are, and particularly older women, with the government covering the financial contributions for the most vulnerable older people, or providing direct services to them. There are many examples of African countries now moving towards universal health coverage. Burkina Faso, for example, is one. Rwanda is another that place emphasis on extending this coverage to older people specifically. Increasing age is frequently associated with increased healthcare utilization and costs. And when people have to pay fees or co-payments, the amounts are often so high in relation to their income that it is not affordable. And that is why we have mentioned, as I said at the beginning, that one of the key components of universal health coverage is to prevent financial catastrophe. Around 100 million people in the world experience poverty due to excessive healthcare costs. And we define this through people that simply have to incur debt or sell assets in order to access health services, 100 million per year. With the world's oldest population, a country like Japan offers a very good example of their experience of around 50 years of political commitment in delivering universal health coverage. And they have some very sound examples of financing mechanisms, how it's extended to coverage of long-term care and strategic purchasing of services, drugs and devices for older people. They have also built in financing models that reduce cost savings. So by extending universal health coverage across the spectrum, the savings that are accrued can be utilized later in life. So they use the same model also to ensure gender equity in delivering universal health coverage. So I think in conclusion, unfortunately we need to say that ensuring health coverage, universal health coverage, and long-term care for older people is still a distant ambition in many countries, in fact in most countries. And much more attention will need to be given to the links between universal health coverage and population aging if we are to achieve the Sustainable Development Goal 3, healthy aging for all, at all ages. Thank you.
Thank you, Werner. That was actually a very good reminder of the transformative potential of addressing this issue, especially in the context that we are in, and opportunities as well that we get from the SDG agenda to advance this forward. I'm going to turn now to Caroline Schmidt, who I think the best bio that I can say for Caroline now is that she's my partner in crime for the work that we're doing on the Tishfield Group, but it's been a pleasure to work with Caroline. She's the chief of the Fertility and Population Aging section in the Population Division in the UN Secretariat, and she's led a quite innovative project on measuring multiple indicators on aging in sub-Saharan Africa, which she's going to talk to us about. Do you have a presentation as well? Yes, which is online.
Can you? Thank you.
Yes, you have the floor, Caroline.
Well, thank you. I try to stick to my maximum 15 minutes, and sometimes I know we get passionate, and then we just get going, and then we say, whoops.
10 minutes.
Up. Okay. 12. Anyway. It's a challenge. I was, briefly, I run this project. It's called a multi-indicator survey on aging. That was a project we developed from 15 to 18, and the purpose was to develop a standard methodology survey instrument that included questionnaires, interviewer manual, sampling methodology, costing, copy, so everything to really have an instrument for sub-Saharan Africa to assess the situation of older persons along the MIPA priority areas. Was a small budget. Everybody who does surveys, when I say $400,000 to do the whole thing, and that meant working in 3 countries, developing the instrument, doing data mapping, participatory workshops, traveling, get people, go to different places, work with consultants. It was a shoestring budget, but I think we're very proud and very happy that we indeed developed the instrument, and we also piloted the survey in Malawi last year. Let's go on to the next. So what we did, I want to talk now a bit more about the data mapping exercise. Whoever is interested in more details on the project, I'm more than happy to respond to specific questions also after the presentation and the event here. What we did was to have a data mapping exercise undertaken in 3 countries, Uganda, Kenya, Malawi, where we had 3 consultants, and we gave them terms of reference and asked them, find out what data do we have on older persons, and look at censuses, household surveys, vital registration, other administrative data, and also international data sources. Also look at the data providers, NSOs, Ministry of Health and other ministries, academia, civil society, international agencies. And also give us an idea of what is the national background, what's the legal environment guiding data collection, storage, use, and data sharing. And it was quite interesting to see, whereas if somebody has an idea, you think the 3 consultants give you pretty much a similar response. So it was quite interesting to see that different people look at these questions from very different angles and also different realities, even in Africa. Realities are very different. So we had Kenya is different from Uganda, and Uganda is different from Malawi. So what I'm doing is really to give you a snapshot, a summary of the findings in these countries. Next, please. So what we found is, I'm just picking a few of the indicators that I thought are important for the discussions here. Disability, we know we had the Washington group is a very active and one of the oldest city groups. So we have the standard questions for censuses, and of course that helps to use these questions. What we also get is nationally and international comparable responses. Sometimes we see in surveys only selected questions. Hearing, visions, and other impairments are not included. And of course, what we don't get is information. What we often don't get is the use of assistive devices, cause of disabilities. Something went wrong there. Anyway, what we did, yes, the disability, we focus on the 3 MIPA areas. We are not going anywhere else. And what the survey also did not do, it was not a medical survey. We didn't have any medical examinations. We didn't draw blood. So it was really self-reported. So I think that is very, very important to mention. Generally on morbidity, often there's a lot of administrative data from health ministry information systems, but often these data are cases, and these cases are not related to individuals. So an individual goes 3 times or 5 times or 10 times to a health facility and is reported 3 times, 5 times, 10 times. So often the data are not connected to a specific individual. And of course, we only get the information of those people who actually seek treatment at government health facilities. What I also want to say is we really looked at nationally representative data. We know there's a lot of different surveys, academia does surveys, NGOs, universities, but it's at a smaller scale and often not representative even at the subnational level. So our focus was to really get information that could be used at the national level. HIV/AIDS, we know we have some information on infected individuals, again, often those who go for treatment, but we know nothing or almost nothing at the national level on the risks, the cause of infection, and of course access to treatment, type of treatment, duration of treatment, efficiency of treatment. Non-communicable diseases, and a lot of these issues were already touched upon by Patricia, so I'm trying to go a bit faster through all of those. But again, we know a bit about the prevalence, but often we look at information on the key non-communicable diseases such as hypertension, heart disease, sometimes diabetes, depending on the part of the world, but often mental health and related issues are not collected. It's much more difficult to collect. It needs more time, and we all know whoever does surveys, each question, each additional interview has a price tag, and usually surveys are quite expensive. Next, please. Another issue that was already addressed by Patricia, and of course, no surprise, Africa, same situation. We don't know much about access to health care. Some information is available. We have some surveys where we would know the distance to the nearest public or private health facility in some countries, but often we don't have systematic information on accessibility, what types of services, the quality of services, and of course availability of medication, affordability. Do people get it once? Do they get it twice? Is it available in the public, from public dispensaries? Do people have to buy it? That is something we don't know at the national level in a systematic way. Health insurance coverage, well, I think most of us who work on aging and health, particularly in developing countries, know most people don't have health insurance. And even in the developed world, in the United States and others, and we see now the discussions, health insurance coverage is a challenge, and a lot of people have the bare bones, even in the developed world, and are often not covered. And as Werner just said, often health issues become a poverty risk, and it doesn't affect only one person, but it affects entire families. Healthy living, what do we know about healthy living? Again, living environments, we know often it is collected at the household level, so we know about the housing situation through censuses and household surveys. We know about access to water and sanitation. And food and nutrition, similar. We have limited information, certain surveys collected at the household level, but then it's proxy information. We talk to heads of households, and it's often very difficult to relate that information to older persons if the older person is not him herself, the head of household. And we also know that sometimes older persons are the last to eat in a household, and so it's really a good or a bad or a very limited guesstimate that we could derive from household head-related information. So where do we have gaps? Where do we have pretty much nothing? We don't know. I would say, at least in the countries we have looked into anything about the prevalence and types of nutritional diseases, any deficiencies, vitamin-related deficiencies, any food deficiencies, we don't know much. Dietary consumption among older persons, what do people eat, what kind of food do people get in care institutions, what is the quality of food, the timeliness of food, all that we don't know. We don't know anything. Also, of course, a lot of these questions, we know nothing about how older persons perceive that, how older persons would validate the food they get. If we have information, it's often, again, administrative information from hospitals. You get the type, you get how many potatoes, how much meat, and whatever, but you don't know how was that received and perceived by older persons. We also know nothing about reproductive health, and I've worked in that area myself, and we all know that according to many, reproductive health stops by the age of 49, and after 49, women don't have sex and women don't have any reproductive health care needs. So that is definitely an issue where we have to push more and more to make people think, change their thinking, and don't stop. Sexual health needs do not stop at the age of 49 because it's more than just family planning. The other thing we don't know much is about medication. As I said before, availability, affordability. Is it appropriate? Do people adhere to any regime they get? How often do they have to take medication? Do they take it once? Do they take it twice? Do they give it to the neighbor? Do they sell it? We don't know. So I think there is a lot of knowledge that would be needed in order to address healthcare services and the provision thereof much better. I think there's one more slide. Yes, another list of issues where we have gaps. Prevalence of dementia among older persons, also the type of support older persons receive, the quality of support, then also patterns and levels of mental health among older persons. Gender aspects and all these variables are very important. Of course, we always think older persons is one group, but we know, depending on socioeconomic conditions, older persons are as diverse as any other age group is. So even we, when we talk about aging, have to be mindful of that. Then the whole issue, I think Patricia also mentioned, old age acquired disability. We don't know much. The impact of it, what's the impact on the quality of life, impact on access to health care, impact on access to food, quality, transport, we don't know. Assistive devices to cope with disability, what do we know? Very little. What kind of long-term care support do people get? Question mark. Number of older persons who are receiving long-term care? Question mark. And of course, the big black box is violence and abuse of older persons, and that again has a gender aspect, but it's not only women, but we know it's a majority of women, and we don't know much in a systematic way. We see it in a lot of countries, it flares up if something really bad happens. I've been involved in work against witchcraft in Malawi, and yes, when somebody gets beaten to death, it goes to the press, but then it calms down, but to systematically address the issue and based on empirical facts is very difficult. One more, yeah, I think I'm doing well. Next, please. What are the challenges? Again, I think most of it has been addressed by Patricia. We have to address really what are the most efficient and effective ways to cover the gaps. And same thing as said before, national data. We have a lot of information. We often hear we have nothing, and that's not true. We have a lot of information. Often it is administrative data, what we call is dirty data. As I said before, you have cases and not incidences per individual. So data needs to be put in a proper format. But that would be, I think, more sustainable than a lot of new surveys that are also pushed by the donor community. And I think we all have to be blamed for that, because it's nice, you have a nice publication and everybody is happy, you launch an event. But the sustainability and the price tag, I think more and more people know that's questionable. The whole issue of metadata, and being a demographer, researcher myself, we know often we compare apples and bananas, and it's done in the area of poverty measurements, it's done in pretty much any area, and of course everybody wants numbers and thinks there is one number and that is one size fits all, and that's not the truth. And being back in the population division, where we spend a lot of time and efforts vetting data, looking at different data points for different times, for the same time, and different data sources, so where you really have to have a sound understanding of what's happening on the ground and to get a good understanding of then what data you have and what comes finally close to the truth. I think I addressed the issue related to surveys, data vetting. I think one more. Last one. Yes, what are the opportunities? I think I want to end on a positive note, because not everything is doom and gloom. I think we should use what we have. We can push for more data disaggregation. As I said, often it's called 60 and over. 65 and over, that's the same nonsense as saying 65 and under and 60 and under. So I think we have to push for that. Another point was addressed is access to data legislation. I've worked in the Caribbean for many years, and it was extremely difficult. Yes, microdata is important to protect personal information, but to store data you collected and it's not used by nobody, then it's a waste of time and money. So I think there is a lot of room for improvement, and I see things happening. The other issue is remove age cap of existing surveys. And we also know the statistics division is supporting countries at the national level to establish national data platforms, pretty much to support countries with SDG reporting and monitoring. The Titchway group was already mentioned. And I think what is important, a lot of people like to collect. You do a survey and you have 20 people in the room and 20 people give you 20 different sets of questionnaires. But then who is using the data and why do you collect the data? What do you want to do with the data? Then you get the looks. So I think it's very important that we really know what we need and why do we need the data, because as I said, anything related to data, you need quality and it has a price tag. So I would think sometimes thinking before and streamlining, and less is more. And of course, right now, I think what is good within the SDG discussions, that we really go back to the recognition that we need good data, solid data. So I think there's now a push also outside the usual suspect statistical communities, data-driven people, to really push for good data. And of course, aging, I think aging is a success story, and that means we are more in numbers and older persons can't be hidden anymore. So I think even the last politician recognizes that we need good data, good information to succeed at achieving the 2030 agenda. Thank you.
Thank you, Caroline. I think that's excellent work that shows how it's possible to address the data gaps, some of those data gaps that were mentioned in the report. But also, I think that a call to actually start using the data, because there's a lot of data available. I think many of the issues that we have around ageism, for example, and the attitudes, we can have evidence now to address some of those issues. Without further ado, I'm going to turn to Mrs. Conchita Ramirez, who is an advocacy coordinator in the district in Colombia, for the District Council of Sages in Colombia, if I pronounce it correctly. Conchita is a recognized activist on aging issues, and she's leading a participation advocacy space for older people in Colombia. Conchita, you have the floor. Thank you.
Quiero presentar a nombre de las personas mayores de Colombia, a nombre del Consejo Distrital de Sabios, a nombre propio, nuestro agradecimiento a HelpAge y a AARP por la gentil invitación para traer ante ustedes los desafíos de nuestra población mayor de hombres y mujeres en esta difícil etapa en la que la humanidad irremediablemente envejece de manera acelerada y preocupante.
Good afternoon, everyone. I am here to represent the older persons of Colombia in the name of the District Council of the Sages of Bogota, and add my own name to thank HelpAge International and AARP for their kind invitation to present the challenges that our older women and men face in this difficult time when humanity is aging at an accelerated and worrying pace.
El censo realizado el presente año por el Departamento Nacional de Estadística en Colombia indica que la población vieja, mayor de 60 años, equivale al 13.4% de la población total, que hoy se estima en cerca de 50 millones de habitantes. Este porcentaje equivale a 6.500.000 personas mayores, de las cuales solo el 30% ha logrado acceder a una pensión económica permanente, o sea, aproximadamente 1.200.000 personas.
In context, the Colombian census of this year indicates that the older population, those more than 60 years of age, are equal to 13.4% of the total Colombian population, estimated at about 50 million people. I like to speak in statistics more than percentages. That number of older persons, more than 60 years of age, is 6,500,000, of which only 30%, or 1,910,000 persons, receive a permanent economic pension.
Este es el punto de partida para esta presentación, porque sin lugar a dudas, contar con un ingreso permanente es una condición determinante para garantizar el goce de una salud que permita llevar una vida digna. Entonces la pregunta que surge es, ¿cómo hacen en Colombia 4.600.000 personas para disponer de una salud garantizada cuando no cuentan con ingresos asegurados que les permitan desplazarse a los centros de atención médica, a los hospitales, acceder a los medicamentos o disponer de un cuidador?
This is the starting point for this presentation, because without a doubt, having a regular, permanent income is a key determinant needed to guarantee a healthy, dignified life. The question that comes to mind is this: what do 4,600,000 persons do in Colombia to receive guaranteed health care when they cannot depend on assured income that would allow them to travel to the closest medical centers, hospitals, have access to medicine, and obtain medical care services?
Las condiciones de Colombia difieren drásticamente de las de otros países latinoamericanos. 50 años de guerra consumieron recursos de todo orden, humanos, económicos, ambientales, de tal manera que los temas de salud no han conformado parte importante de las agendas gubernamentales.
Conditions in Colombia differ drastically from other Latin American countries. 50 years of war consumed many resources of all kinds: human, economic, environmental. Also, health has not formed an important part of the government agenda.
Uno de los grandes problemas que enfrenta el país en el sector salud es la corrupción. Ha debilitado de manera dramática el acceso tanto a la atención médica como a los medicamentos.
One of the greatest problems we confront in Colombia in the healthcare sector is corruption. It has weakened access in a dramatic way, as much as medical attention and medication.
En el corto y largo plazo, Colombia deberá asumir el sector de la salud en temas de control y transparencia.
Over the short and long term, in Colombia, there are three principal strategies.
Existen tres estrategias para lograrlo. Por el sector salud pasa mucho dinero, 16 millones de dólares al año. El sector salud es muy fragmentado, descentralizado, repartido en todos los municipios del país, lo que crea deficiencias en su control. Es poco claro y transparente, tanto en información técnica como en información financiera.
There is a lot of money that passes through the health sector. The amount in US dollars is 16 million or 50 billion pesos in Colombian currency. It is a very fragmented sector, decentralized and divided into all the municipalities of the country, which creates weaknesses in control. It is neither clear nor transparent in technical or financial information.
Ahora, de la población de las personas mayores en Colombia. Actualmente, por cada 10 personas mayores, 8 viven en zonas urbanas. El 30% de ellas todavía trabajan. El 29% recibe una pensión y el 20% reciben subsidios estatales.
The current older population of Colombia. Currently, of every 10 older persons, 8 live in urban zones, which is 78.1%. 30.9% still work. 29.1% receive a permanent pension. 20.5% receive state subsidies.
Hoy en día, nos preciamos de ser un país con una amplia cobertura en salud. Las estadísticas del Sistema General de Salud y Seguridad Social demuestran que esta cobertura alcanzó en el 2017 el 90.5% de la población, tal vez una de las más altas de América. Sin embargo, es claro que cobertura no significa acceso.
Today, Colombia provides good health coverage. The statistics of SGSSS, Health and Social Security System, show that in 2017, Colombia reached 90.54% coverage of the Colombian population, perhaps one of the highest in Latin America. But coverage is not the same as access. This situation is getting worse. According to the National Study of Health, Well-Being, and Aging, and it uses the acronym SABE, S-A-B-E, by the year 2021, there will be one older person for every 2 adolescents, and there will not be enough comprehensive services to serve them.
Otro estudio realizado por la Universidad de La Sabana y la Asociación Colombiana de Geriatría y Gerontología consultó 30,000 personas mayores en 250 municipios del país y demostró que el 9.3% de ellos viven solos y en Bogotá es el 11% que sobreviven en esa condición. La situación empeora porque no hay suficientes médicos para atenderlos y el 72% de esta población no puede acceder a un centro especializado en cuidados geriátricos ni a un cuidador.
Today, Colombia provides, no, I've done this. Another study carried out by the University of La Sabana and the Colombian Association of Gerontology and Geriatrics consults 30,000 older persons in 250 Colombian municipalities, showing that 9.3% of them live alone. This number rises to 11% in Bogotá. This situation gets worse because there are not enough doctors to serve them, and 72% of older persons cannot gain access to centers with specialized services in geriatrics and care.
En Colombia existen 2 formas de participar.
Tiene que escoger lo que es más importante.
En la consecución ¿sí?
All right.
Bien, tomemos desde... A tener en cuenta.
Okay, aquí, okay.
Voy a señalar algunas de la experiencia que hemos tomado desde el Consejo de Sabios. Okay. En la importancia de la participación. Primero, si lo logramos, sería posible, primero, conocer de cerca el cumplimiento de los mandatos normativos internacionales y nacionales. Segundo, determinar las verdaderas necesidades planteadas desde su cotidianidad y experiencia para que se reflejen en planes de desarrollo y no estar a la deriva de los intereses personales, comerciales y muchas veces fraudulentos de quienes son responsables de elaborar esos proyectos. Hacer seguimiento, reconocer y sancionar cuando sea necesario el aprovechamiento o el despilfarro de los recursos económicos y humanos destinados a garantizar la calidad de la vida digna para la ciudadanía y especialmente para sus poblaciones mayores, quienes son pasado, presente y futuro de la sociedad. Esto es muy importante tenerlo en cuenta. Y cuarto, empoderarse con una participación activa, digna y productiva, exigiendo ser escuchada y respetada.
Participation issue. We must, number one, learn in depth about the compliance of national and international laws affecting health. Number 2, identify the real needs that are discussed and experienced in daily life. These should be reflected in municipal development plans and local investment, not reflecting personal or commercial interests of those in charge. Number 3, monitor, acknowledge, and sanction when necessary the bad use of public resources, economic and human resources, destined to guarantee the quality of dignified life for citizens, especially older citizens, past, present, and future of society. This is very, very important. And number 4, empower their active, dignified, and productive participation, demanding that they be heard and respected.
Okay. Y por último, un aspecto fundamental para garantizar una mejor calidad de acceso a la salud es la importancia de realizar investigaciones mucho más serias en torno a las personas mayores que permitan conocer no solo la realidad demográfica, sino el acceso a la salud, profundizar en sus condiciones de vivienda, la composición familiar, las relaciones con la comunidad, los procesos de crecimiento económico, a partir de la aceptación de la que la persona mayor debe ser mirada de manera integral desde la perspectiva de su experiencia, su vida y su sabiduría.
One key aspect to guarantee better quality of access to good health is to carry out much more serious analytical studies about older people. It is necessary to learn about their reality, not only demographics, but also to deepen our understanding of how they gain access to health services more than the characteristics of their illnesses. It is also necessary to understand fully how they are living, their family composition, their relationship with the community, their economic growth, all those things that contribute to the acceptance of older persons in an integral way.
Yes, this is the last minute. La carencia de médicos geriatras y gerontólogos es una deuda pendiente, tanto al sector académico como de los mismos médicos que accedan a estas especializaciones junto con el personal complementario. This is important now. En Colombia, desde 1982 hasta la actualidad, se han formado 2.000 gerontólogos. De ellos, solo el 4% está en actividad. Actualmente, solo hay 80 geriatras en el país para atender a una población de más de 6,5 millones de personas, de las cuales el 72% no puede acceder a un centro especializado en cuidados geriátricos ni un cuidador. My last word is, por primera vez en la historia del mundo, los viejos no son los individuos, las viejas son las sociedades. Y esto implica una serie de cambios de importancia en las políticas de Estado del mundo entero. Thank you.
Okay. En un momento. The lack of geriatric doctors and gerontologists is a current problem of the academic sector, like those of the doctors themselves. In Colombia, from 1982 through the present, only 2,000 gerontologists have graduated. Of these, there are only 4% in practice. Currently, there are only 8 geriatric doctors in Colombia to treat a population that has increased to 6,500,000 persons, of whom 72% do not have access to a specialized center with geriatric and other care services. This is the last sentence. For the first time in the history of the world, the old are not individuals. The old are societies, and this implies a series of important changes in the policies throughout the entire world. Thank you.
Thank you, Conchita. I understand why you're working for the Council of the Sages. That's a lot of words of wisdom there, and actually a great call for accountability, which you welcome. I really apologize that we had to cut you off because of we're running out of time. But I think that there were important points there on the need for accountability, empowerment, and participation, and this important message that you have at the end, that it's really not an individual problem anymore; it's a societal issue. So we could quite take that to heart. hard. So now this is the moment that you've all been waiting for. I think we're going to take a few minutes. Really, we're running out of time. We'll take a few minutes for question and answers that you can direct for any of our panelists. But I would suggest mostly to Patricia because she presented the report. You can access any of the speakers if they are willing to stay a few minutes to take questions after the session. Please feel free to do that. Now, any questions, please just raise your hand.
Thank you. Cynthia Stewart from the International Federation on Aging. As we approach trying to convince the world globally about universal health care coverage, I would ask the panel, do you think it's the strategy is to try and convince countries on a cost-effective basis of treating people, giving them prophylactic care, focusing on healthy lifestyle, because that covers, we vaccinate children, we need to vaccinate middle-aged and older persons against pneumonia, etc. All of these are things that help keep a population healthy across the life course. You mentioned there are studies, different pockets. Would that be something to pull together in a sort of, one-pager that says why it's important for countries to adopt universal health care? Or is it to really focus more on we the consumers and get a groundswell there, or both?
We're going to take a few questions and then have the panelists respond, please.
Speaking to us today. This has been truly enlightening, and I've noticed throughout the conversation a few things, especially about the data that we know and sort of the data that we wish to find. Things like women outliving men on an average of 4.7 years, fewer access to health care for those in caregiving roles, and some fuzziness with our knowledge of how HIV and AIDS plays into it. I'm just curious about any especially vulnerable populations that among the elderly and the aging, in particular, widows, as I am with Global Fund for Widows, an NGO, and there's huge overlap from our perspective on this as well. Thank you.
Thank you. Any more questions? This is your last chance. If not, then I'm going to turn to the panel. I'm going to ask the panelists to each take a crack at answering, but also giving us their parting words and final thoughts. Right. I'm going to start with Wem.
Let me quickly just respond to the matter of universal health coverage. There is no model which can be applied universally. Each country needs to determine for themselves what are the national priorities, what are the key essential services that need to be covered by government and the private sector. Because in countries like India, 2/3 of healthcare are provided by the private sector, at least 2/3. So it's important to involve the private sector as well in determining the package of essential services that need to be provided. And the indicators that we use, as you have correctly mentioned, fall short. When it comes to the key interventions, we usually look at prevention, but we look at early ages rather than further down the line. And this is something that I think your question was, should it be one or both? It should be both, because the advocacy that you're involved in is key to make governments understand that there should be a more comprehensive look at the age groups.
Thank you. I fully agree to what Werner says, but I would just have a quick response to the whole issue of data and statistics and vulnerable groups. And I think that is the biggest challenge because a lot of these issues, violence, abuse, all of that happens very hidden. And it's often also just quote unquote justified by culture, by rituals. And I would say the biggest challenge, having worked on aging in Africa now for a couple of years, where you really walk that fine line between customs and traditions and human rights. So where do you really say, where is the limits? Where do I respect your culture, your tradition? And where do I say, here is a limit? And when we did the interviewing, the survey, and we did some piloting, and we had some very young interviewers, and I saw their reaction to these questions. And that's where I saw how deeply ingrained some of these issues are. So it's very, very difficult. It's not only a question, it really takes generations to address, to make it an issue, and to have people come around. And so I think it's something that has to be worked on, and we need more forces to join us.
Thank you. Conchita, any comments?
De las viudas es muy delicado, porque nuestra guerra de 50 años arrasó con la población de hombres jóvenes y de mujeres también, porque no había diferencia. Y correspondió a las personas mayores asumir esa responsabilidad. Entonces, especialmente las mujeres, las abuelas, no pueden ser abuelas, son cabezas de familia que deben enfrentar esa condición. En el país no, es un tema que no se ha tratado, que no se tiene en cuenta y que se evidencia no solo en los desplazados, sino en la gente que regresa de la guerrilla y que regresa de los grupos alzados en armas.
Back to the question about widows. In Colombia, this is a very delicate case, especially after our war of 50 years, which affect young men and women, people who were killed. And grandmothers are really not grandmothers. They have to become heads of family and have to help those who are still able to return.
Thank you. Amy, anything?
No, I would just say that this report and this conversation this afternoon has really raised some consistent themes around data, around access issues, around collaboration across sectors, and being person-centered, all of which AARP supports. I would say also another piece of the puzzle is adding in more visibility for employers and for the private sector and the role that they play in scaling and providing support, not only to their employees who are potentially caregivers, but also across the systems.
Thank you. Patricia, I don't do this often, but I'm going to give you the final word.
And I'm going to enjoy it. Okay. So thanks very much, Serge. And thank you to all of you for listening so carefully and for your questions and comments now. So I would say a number of things. I really like the emphasis on participation that has been shared by all of us. And I think there is something for all of us, beginning with where Ambassador Hasbun started this afternoon, in terms of informed participation in relation to the work that is going on at the World Health Organization at the moment, in relation to UHC indicators, in relation to the negotiations that will go on in relation to a UN decade for healthy ageing, in relation to the fact that DHS is launching a consultation, which happens every 5 years, so the moment will be coming in January, in terms of how it runs its surveys, and in terms of the fact that Titchfield is in place and in action and needs to be supported, and also the high-level meeting next year in relation to UHC. So our role, I'm speaking from a civil society organisation perspective, in terms of being as informed and as agile as we can possibly be in our participation in those moments and opportunities. I think in terms of the question around how do we strike this balance between rights and economic justification, if you will, for what we're asking for. And obviously there is an economic justification and we have to be aware of it. From a HelpAge perspective, we'd always promote the rights perspective and be very, very clear in relation to that. I think it does. I suppose the question I would leave you with in relation to it is, what's your essential view of the contract between decision makers, governments and citizens? And if your essential view is of fairness, and of equality and of societies being better for higher levels of equality and fairness, then I think that just casts a different light on the question you've asked. But that's, I mean, obviously it's a point of great discussion globally at the moment. And then finally, we've said plenty in relation to data gaps. I won't go further on that. But in relation to your question around the vulnerable groups and so on, I think it's terribly important. In relation to widows, obviously if we're disaggregating the existing data and using it better, we will do better with that. So that's number one. And it just allows me to say that there are very vulnerable groups of people who don't live in households. So you have older people who are in nursing homes, people who can't give consent to participate in standard surveys because they have a cognitive impairment, people who are homeless. I've been shocked at the numbers of older people in both low and high income countries whom I see sleeping on the streets. So there are real issues that we have to address in terms of this data journey, if you will. So there, and the very final question in terms of my colleague from WHO, as we know, all of the member states have signed up to a national or to implementing national plans on ageing as part of GSAP. So it certainly needs to happen at the national level, but we certainly need to be pushing for the accountability that Conchita spoke of when she highlighted how resources and energy can be wasted. I think, yes, energies are constrained, but they should not be wasted. Okay, thank you very much indeed.
Thank you, everybody.